In today's episode, we're going over a case study of a rotator cuff repair and a CrossFit coach. So, rotator cuff repairs are one of the most common surgeries out there, right? But I don't think there are very many physical therapists who are actually sharing the nitty gritty of what they do from kind of step one all the way up to step 10, back to return to sport and everything along those lines. What I wanted to do today for you is to give you an inside glimpse into how I rehabilitate folks after rotator cuff repair. So it's going to be a CrossFitter as well as a CrossFit coach. So in today's episode, we're going to be going over an initial diagnosis of what this individual had before going on to get surgery. What was the mechanism of injury? How did they get hurt? What was the actual relevance to rehabilitation, right? Sometimes that mechanism of injury is going to be important for how we rehab. What was the person's prior injury history and how did that reflect into rehabilitation? Who do we decide on in terms of a surgeon? We'll talk a little about the surgery specifics. So, what type of rotator cuff tear was it? What was the repair? Was there any concomitant pathology, right? Was there any arthritis or anything else going on inside that thing? What did our early physical therapy care look like? What did it look like as we started to advance over the course of time? How do we discharge? How do we return back to CrossFit over the course of time? We'll go over all that stuff. Before we really get going, I want to tell you about a free download I have for you that's going to allow you to understand this pathology inside and out. It is a rotator cuff pathology cheat sheet. I will leave a link in the show notes so you can definitely go ahead and download that and get started. We go over evidence-based treatment of the rotator cuff with tendinopathy as well as rotator cuff tears. We go over the prevalence of these injuries. We go over anatomy, mechanisms of injury. We go over the clinical presentation of these. We go over evaluation and diagnosis, as well as treatment strategies, and also surgical considerations. Who should go on to get surgery after rotator cuff tear and who shouldn't? So I will leave a link in the show notes. Definitely go download this now for free. So who are we actually talking about today in this case study? Well, it's Brian Curley, right? So I'm not sure if you guys have heard of him. He's a very high level CrossFit athlete. He's competed at the CrossFit Games several times. He's currently not competing, at least not as competitive as he once was. But he's a great wealth of knowledge in the CrossFit community and is currently a coach. Okay. He's a 62-year-old male. And in terms of prior injuries that he has had, at least on the right side, he's had a tenodesis and a labral repair. In terms of goals, what does Brian have after this repair? Well, one, he just wants to kind of stay fit and healthy. He wants to be a better coach and a better role model. He's not actually trying to go back to higher level competition just because he's been so beat up over the course of time, just wants to enjoy his fitness moving forward. He will probably end up doing some local competitions. He's a competitive person, right? So we're not completely moving away from competition, but we're definitely reducing the amount of competing that we're doing in the future. He wants to be a master of technique for the Olympic lifts, as well as some of the gymnastics movements within CrossFit. So he really is not looking to get back to CrossFit quickly. He wants to get back as slow as needed. He wants to have a nice, smart return. So we don't have to rush anything. There's no no deadlines. So what are some important psychosocial considerations with Brian? Well, one, he's extremely dedicated, right? One of the hardest working guys I've ever had the opportunity to work with. If I tell him he needs to work out 17 times per week, right, twice a day, he's going to do that, right? He has this massive discipline. I have to be careful, but because of that, he's kind of that classic overdoer. So from an athletic identity standpoint, he identifies as a strong, fit, capable person, right? And he's definitely going to do exactly what I tell him to, which is going to really help my work as a physical therapist because I can essentially tell him to do exactly what I want to do. I know it's going to get done. It isn't his first injury. He's been injured multitude of times, right? He's been competing in sports and pushing CrossFit hard for, I don't know, probably about 15 years. And he was very athletic before that. And he understands the process, right? And lastly, he's essentially retired in one sense because he used to work a lot. Now he's worked a lot less right now, anyway. He works part time as a CrossFit coach. So he has quite a bit of time to rehab. This is a very important part of his life. So he's going to make the time for it, and he has the time for it. In terms of relevant injuries, he's had some pretty serious pain on the left side shoulder in the past. He has quite a bit of arthritis on that side. However, his left side is actually his stronger side. On the right side, he's had a prior surgery, so he's gonna have a current surgery now on the right side. But in the past, he's had a labral repair and tenodesis on that side as well. And despite having a prior surgery there, he's actually more mobile on the right side, probably because this was his mobile side prior to this, right? The other piece is this right side was historically weaker than the left side. So after the rotator cuff repair, we're gonna have our work cut out for us. We really have to work hard to build that strength back because it was already weaker going into it. And like I said previously, he's a seasoned rehabber. He's done this several times. I've had the opportunity to work with him in the past. I know he knows what he's doing, and that's definitely gonna help me out as a physical therapist. So, what was the mechanism of injury? How did he get hurt? What was that injury? Well, he had a traumatic rotator cuff tear. And what he was doing was dumbbell pressing. So, he had some heavy dumbbells, and on the bottom of one of the reps, he kind of lost the weight behind him a little bit. He tried to save it, and then he just felt a sharp pain, kind of a tearing sensation within the shoulder. So, he went to see the surgeon and they ordered some imaging, ordered an MRI. And what they found, like I said, was a rotator cuff tear, but it was a tear of the supraspinatus tendon. There's also a full thickness rotator cuff tear. It was a large tear, and there were a lot of loose bodies. Afterwards, the surgeon kind of remarked to me that there was a surprising amount of osteoarthritis. I think there were 15 loose bodies within the shoulder joint. So it's just a sign that shoulder has taken a lot of, I don't know, wear and tear over the course of time. Shoulder's been working for the majority of his life, right? So, along with that full thickness rotator cuff tear, they also found a bunch of arthritis in there. And what that means to me is that A, we have a large, full thickness rotator cuff tear. We have to really respect that. Probably have to slow down rehabilitation a little bit. But the other part is the shoulder is a little beat up going into it. So, quite a bit of arthritis. And I think you can make the argument that you probably want to progress a little bit slower just because of the other concomitant pathology within the shoulder joint. So next, Brian just has to make a decision. Is he going to get surgery or not, right? And basically, he made that decision with himself. A little bit of feedback from me, and also information from Dr. Sean Rocket, who is a phenomenal surgeon that I really trust. He works with a ton of CrossFit, and they just kind of decided together that they're going to end up doing the surgery. Now, why did they decide upon that? Because I'm sure you've heard folks will tear the rotator cuff, and sometimes they don't need surgery. Well, for one, it was a full thickness tear. Generally speaking, full thickness rotator cuff tears will continue to tear more over the course of time and faster than a partial thickness tear. And the other piece is that if you have a large enough tear, the outcomes from a surgical perspective generally end up getting worse, right? The other piece is that when Dr. Rocket went in for the surgery, there was quite a bit of retraction present, which is also a sign that it was probably better that he got it repaired sooner than later, just because large, full thickness tears with retraction probably end up A, being painful, B, end up worsening over the course of time to the point where if he delayed this, he might not have the option to perform surgery a little bit later. Okay. And the other piece is that it was a traumatic tear, right? He lost a dumbbell behind him. And think about it from this perspective. So if you have a chronic rotator cuff tear, let's say that it tore and has maybe it began to tore years ago and kind of slowly tore over the course of time. As that tendon disconnects from the bone, what happens is that the muscle will end up having atrophy and fatty infiltrate, right? The muscle tendon will get stiff and it's hard to pull that muscle tendon back onto the bone to get a good attachment, right? However, if you had an acute injury, so it just tore, just pulled off, the tendon is actually pretty healthy. So it has quite a bit of hypertrophy, no fatty infiltrate. When we repair it, it's probably more likely to heal back onto the bone as a result. So acute cares tend to do a little bit better. And despite Brian being 62, he's still young. That's a young age for folks to have rotator cuff pathology. He wants to get back to high level training. So I think for him, it's worthwhile that we repair the tendon, get the function back, get the strength back, so you can do higher level activities, right? As opposed to saying, let's not worry about it. I'm not going to get surgery, which may not lead to a very good long term outcome, right? So I'm sure you guys know that I'm a huge fan of physical therapy. Unfortunately, a big chunk of physical therapists don't feel like they're paid enough for their level of education. According to the American Physical Therapy Association, the average physical therapist is graduating with $150,000 in debt. That's why I feel very strongly that physical therapists should have some additional ways to bolster their income. I am a really big fan of physical therapists writing strength and fitness training programs for their patients after discharge, as well as continuing with cash based physical therapy after insurance has run out. However, once you start doing this, this is going to come with some technical issues. So, how are my clients going to schedule with me? How am I going to start accepting payments? And what platform should I use to show my exercises and programming? Well, I like Curve Health to solve all of these issues. Curve is essentially a one stop shop for clinicians that are trying to extend their reach beyond their traditional clinic. It has simple scheduling, You can block out times in your calendar so that clients can effortlessly sign up and have a one on one session with you. Curve has secure payments. Curve will handle and automate all of your payments. They also have dynamic programming. That means they have an extensive library of exercises you can draw from for your clients. Or if you want to, you can actually take your own videos and upload that into Curve. This way, you can easily create tailored programs for each of your clients. They've also just launched a fast growing marketplace, which is really exciting because they have people online that are looking for help, just like from folks like yourself. And through this marketplace, you can get some extra business, and these people can sign up directly with you. Honestly, Curve is the program that I wish I had as a new grad when I was in a ton of debt and was looking for ways to get a little bit extra income. And I was trying to see patients after discharge, but it was just a pain handling all the scheduling, billing, so on and so forth. If you want to learn more, check out the link in the description below. What's also pretty cool is that if you use this link, then when you sign up for the annual plan, you'll actually get 50 bucks back at you. So just for sign up for the annual plan, you make an extra 50 bucks back. In my mind, Curve is a no-brainer. Go ahead and get started. Talk about Brian's training age. Well, he's been training for a long time. He's been doing CrossFit basically since CrossFit started, right? Very seasoned CrossFitter. But he also has a large history of weight training. He loves exercise, it's a huge passion of his, right? And he's very, very good at following training programs. So I know for me, I can basically say, hey, do this exercise, do this exercise, do this exercise. He's going to know how to do it. I'm not too concerned with his technique always. Obviously, I'll take a look at it. If there's anything concerning, we can change it. But generally speaking, I know I can give him a program. He's going to follow it. His technique is generally going to be pretty good. I don't have to worry about, watching every little thing he does because I know he has a very big training age. He also has a background as a coach. Makes my job easier. So Brian goes in for surgery and it was a success. Phenomenal, right? So I like to communicate a little bit with the doc. So I ended up emailing Dr. Rocket to ask a few questions. He sent over the post-op report. He also gives me some guidance on what he wants me to potentially avoid or when it's okay to push certain things or when to hold back, right? And he bases this off of all the information I talked about before. So essentially, how large was a rotator cuff tear? Was there any fatty infiltrate? All of those type of things, right? So the guidance that I got from Dr. Rocket, as well as the contraindications, for one, he wanted to wear a sling for 4 weeks, right? If you want some evidence-based guidelines for rehabilitation after rotator cuff repair surgery, I did an entire show episode about this. I'll leave a link in the show notes. But largely, if you wear a sling for a long period of time, so 4 to 6 weeks, just going to make that shoulder really, really stiff. Okay. So, in a lot of ways, that's probably good because we kind of want this area to scar down a little bit. We want that stiffness. It's a large, full thickness tear. There was retraction there. So, we probably want this thing to stiffen down a little bit so it'll heal a little bit better. If we push it a little bit too soon, right, potentially take away the sling, have Brian do a whole lot more on his own, there's a chance we increase the risk of a re-tear. So, that was the reasoning behind adding a sling for 4 weeks, right? Dr. Rocket also wanted to be very conservative with this one. So he was kind of requesting passive range of motion only for around 8 to 10 weeks, right? And basically around 8 weeks, we can start to transition to active assist range of motion, right? And we'll talk a little bit later that the line between passive range of motion and active assist range of motion is a little bit blurry, right? And we'll see why. I'll kind of break this down. So like I said, this is a larger tear with retraction, and the doc was a little bit fearful of the degree of the shoulder injury. So he just wanted to make sure that we didn't push it too much, right? But here's the thing. If you're waiting for around 10 weeks in order to actually push someone's rotator cuff, you're going to have a lot of atrophy. And I mean a lot. And I'll show a picture a little bit later of Brian after the surgery, but he's a very fit, strong person. You just kind of notice that the arm kind of dwindles into nothing, especially in comparison to the opposite side if they're actually, training that side, the contralateral limb. So we just have to keep that in mind. We know that Brian is going to get quite a bit of weakness over those first 10 weeks or so. And we really have a large mountain to climb once we get to that, 10 to 12 week period, we can start to push. The other thing is that if you are delaying this long to start more active range of motion and more strengthening, that's going to delay everything. So just keep that in mind. So when you start resisted range of motion, when you start, let's say, bench press or overhead press or snatching, whatever it is, that's going to be delayed even further just because you had to wait so long to initiate these things. So week 2, what do we see? Well, for one, I always like to take note of what the skin looks like. Does the incision look good? Does it look like it's opened up, right? Is there any kind of redness or signs of infection, right? And I didn't see anything, so no signs of infection. I always like to try to educate the patient and say, hey, if this is getting more red, any red streaking, just make sure that you tell the doctor it's not a good thing. You may be developing an infection. So if you see that, contact your doctor right away. The other thing that I noticed and actually got worse over the course of time. So think about it. Basically, I took this picture at week 2 as soon as physical therapy started. And if you're watching this on YouTube or the video version of the podcast, you'll notice Brian has quite a bit of atrophy on that right side trap, the back side of the scapula. You can kind of see a divot right where the infraspinatus is. I know this is not the best picture in the world. And the lighting is not great. But take my word for it, there's quite a bit of atrophy in the delt, infraspinatus, teres minor, upper trap, supraspinatus. It just looks like there's a lot less mass there in comparison to the left side, right? So if at week 2 things are looking like this, and he has another 6 to 8 weeks of not moving his shoulder, he's going to get even more atrophy, even more weakness, right? Thing is, if we push this thing too early on, we can increase the risk of re-tear. So I just want to note this. I'm not trying to say that week 2 you should be pushing strengthening. You certainly should not, right? But because there's such a period of time where we're not able to push this because we're protecting the rotator cuff repair site, you're going to have a lot of atrophy as a result. And just be prepared for that. So what did range of motion look like at week 2? Well, flexion was at around 100 degrees, abduction around 100, external rotation with the elbow at 45 degrees of shoulder abduction was around 45 degrees. Internal rotation in the same position was around 45 degrees. And essentially, the physician protocol, so Doc Rock was cool with gentle passive range of motion, right? And basically until around week 8. So Dr. Rocket really wanted gentle range of motion for the first 8 to 10 week-ish. He didn't want to push things too much. So it was pretty conservative in the start of physical therapy. So this show is not meant to be a replacement for a protocol from a surgeon, okay? I'm not trying to give you those guidelines again. I made a fitness pain-free show episode where I go over evidence-based treatment of rotator cuff repairs. Leave a link in the show notes if you want to check that out. If you want a good protocol, I recommend the protocols by Wilk and Andrews, Lenny Macrina, Mike Reinold, all great rotator cuff folks, as well as the protocols from Delaware University. I'll leave a link in the show notes if you guys want to check those out. So what was our decision-making and clinical reasoning for the early stages of rehab? So I already mentioned this, but I think the biggest goal at the beginning is to protect the healing cuff tendon. Because if we do too much too soon, and I would say generally the evidence we have about rotator cuff repairs does support this. If we do too much too soon, we may increase the re-tear rate of the rotator cuff. And the problem with rotator cuff repairs, especially with these large and massive tears, is that the re-tear rates are quite high. So above 50%, upwards of 90% in some studies. So we don't do everything in our power to let this thing heal in the beginning stages, right? Because largely when a rotator cuff re-tears, it generally happens in the first 3 months. Okay. So those first 3 months are actually going to be super important. We want to make sure we don't overdo it in that time period. Allow this tendon to heal down as much as possible. Okay. Now, in terms of the movements we have to be most cautious with, abduction or flexion is going to be the biggest one. And that's just because the supraspinatus is what was repaired. And obviously, the supraspinatus is very active when you do any sort of abduction or flexion. The other piece that we have to be cautious with end range stretching. Okay. So I just said this before, but we kind of want that shoulder to stiffen up a little bit. If at the very beginning of rehab, I'm pushing aggressively to try to stretch the shoulder, I'm not allowing that stiffening to occur. So I'm actually okay if the shoulder joint gets a little stiff in these early stages in PT, and I see that as a good thing, right? Next thing we're looking to do as much as possible, and in the early stages of rehab, we can't do much against this. We want to try to prevent atrophy as much as possible, all right? So when we're able to, as soon as we're able to, we want to start putting a little bit of stress through this area. If we're going to be choosing some sort of motion, we obviously want to choose exercise with low EMG. But I'll tell you what's probably okay, what's not okay in the future as we make decisions about the right exercises. And I'll show you exactly what we did. We're looking to maintain sport and physical qualities as much as possible, right? So Brian loves exercise, and having a rotator cuff tear is a real bummer, right? Because A, it hurts, it's hard rehab, but B, it keeps you from being able to exercise. It's super important for Brian. So as much as we safely can, we're trying to maintain all of his lower body training, as well as training for the opposite side limb, right? Now, Brian actually stayed out of the CrossFit gym for a long period of time. which I think was actually pretty good for him. And he just knew that if he was in the gym, he was probably going to get pushed into doing something he probably shouldn't do too early on. He kind of knew himself. So I think it was actually a pretty good decision. But we'll talk about how we made that transition eventually back to CrossFit because we did end up getting there, right? And then lastly, how do we ramp up to get back to CrossFit? And we'll kind of go in depth about how we did that when we incorporated certain movements and how we progressed back to Metcon and all the like. So, what was the plan of care with Brian? We started off with 2 times a week with physical therapy. Then I gave him a home exercise program to do on his off days, right? And our decision was kind of, all right, well, 2 days a week, 1 to 2 days a week is probably a good place to start. And if we're noticing that you have more pain or you're getting really, really stiff, we can always increase the frequency of physical therapy. But generally speaking, I'll start with 1 to 2 days a week. And if things are going really well, we can maintain that or do a little less. And if things are not going well, we can always bump up the frequency of physical therapy. So we ended up continuing with physical therapy 2 times a week for about the first 12 weeks. And then there on out, we did PT 1 times a week up until about the 9 month mark. And I think we had a few intermittent visits at the very end there, close to the year mark. But largely, that's how we ended up doing our physical therapy. So, one of the biggest goals between week 2 and week 8 was to restore range of motion. And we spent around about 30 minutes per session strictly working on range of motion. Okay. Now, keep in mind that these sessions were really, really boring, mostly because we weren't able to do much. We're trying to protect the rotator cuff repair and just make sure we aren't putting too much stress through there. So, what we're left to do is a lot of passive range of motion, working on things like pain, trying to improve mobility at the shoulder, right? So essentially, at the start of every session, I would measure range of motion because I want to get an idea of how the shoulder looks cold. Because oftentimes we only take measurements after we mobilize the shoulder. And it's really not a great reflection of how the shoulder normally is in terms of stiffness, right? And basically, we'll use range of motion as a guide in terms of how hard we need to push in terms of prescribing exercise from a home exercise standpoint. So let's say if you're getting more stiff, then maybe we're overdoing it with exercises. You can also make the argument that if you're not making progress with range of motion, we can always incorporate more exercises at home. So in terms of soft tissue mobility, what muscles were we focusing on? We're focused on the lats, teres major, all very important for overhead mobility. We worked on the posterior cuff, which is going to be helpful for improving internal rotation, range of motion. Worked on the upper trap, levator scapulae. One of the major reasons we put effort there is just because after you have a cuff repair, the shoulder joint doesn't want to do its job. Upper trap is usually overactive. Plus, you're in a sling, stuck in one position for a long period of time. These folks tend to have a lot of shoulder pain, a lot of tightness in the upper trap, levator scap. They usually find a lot of relief by working on that area. I also work a bit on the pecs, the delt, as well as the subscap. So those muscles are also going to limit range of motion. In terms of range of motion, we really worked all directions, right? The thing is, we just have to be a little bit careful with internal rotation range of motion. We have to be a little bit careful with extension range of motion. We have a bit of research coming from Segroy et al. In 2018 that going into internal rotation with your mobility is going to increase stress on the rotator cuff. So we just have to be cautious when we're trying to push that direction. And the other thing I will say is that extension tends to be this forgotten range of motion within the shoulder joint in physical therapy. For some reason, we work a ton of flexion, internal rotation, external rotation, and then we just forget that extension exists. So just make sure that that movement is on your radar and you're assessing it just like you're assessing any other movement, right? Early on, I was also a fan of doing joint mobilizations. So I focused more on posterior and inferior mobility, which generally helps with overhead. So flexion, abduction, mobility, also some global distraction. I didn't do a whole lot of anterior shoulder mobs. I personally find these to be a bit provocative. They are, in theory, supposed to improve shoulder external rotation. So you can make the argument that if someone's very stiff into external rotation, you do some more anterior mobs. But keep in mind, they can be provocative, right? Basically, with mobility exercises and Brian, we continued until about week 10. Because what we found is that at week 10, he actually had more range of motion on the surgical side than the non surgical side. And like I said in the past, the right side historically had more mobility than the left. So after a period of time, we ended up switching gears and we actually prescribed a few mobility exercises for the left side because that was limiting things like his front rack and overhead mobility eventually, right? So essentially, we worked on range of motion until it was actually pretty good. And then we substantially backed off of the amount of mobility work we did over the course of time. So, what did the home exercise program look like, right? And this was the home exercise program between week 2 and week 8. And I think it's worthwhile to mention a little bit of research about how much stress certain physical therapy exercises place on the rotator cuff repair. Now, generally speaking, and you can read this study if you'd like to, Edwards et al. In 2021, they note that around 15% or less EMG of the supraspinatus. So if you take someone and do a full can exercise isometrically and have them push as hard as they possibly can, that would give you 100% MVIC of the supraspinatus. And then basically, we want to make sure that when we prescribe exercises, we use ones that are less than 15% EMG. And we have a decent amount of research at different exercises to see just how much stress each exercise places on the rotator cuff repair, right? And then we can use that information to decide which exercises are safe and which ones are probably going to be a little bit too much. Okay. So in this study by Edwards et al. In 2021, the only movements that didn't put too much stress on the rotator cuff, so they were below that 15% MVIC, were pendulum exercises and small pendulum exercises. If the pendulum gets too big, it's actually a little too much stress on the rotator cuff tendon. Table slides, which is basically sitting next to a table and sliding the arm back and forth, which is largely consisted in active assist range of motion exercise, but it actually is less stress on the rotator cuff than other exercises that we consider passive range of motion. And then an assisted wall slide. So basically sliding your arm up the wall, but assisting with your opposite arm, right? Which honestly is, as a movement, that one freaks me out a little bit, but it's generally low stress on the supraspinatus. And the other piece, and we'll talk about this later, but we need to make sure that our brain is not doing too much at home, right? And this is, I think, one of the reasons why it's good to have a sling early on, because the stress on the rotator cuff can be actually pretty dang high during normal activities, right? And I'll give you a little bit of research later so you can see exactly how much regular activities are. But to give you a little sneak peek, something like brushing your teeth is around 12% EMG of the cuff, so largely safe. Typing is around 7.5, but something as simple as drinking water is 21, which might be a little too much in the early stages after rotator cuff repair. So not only do you have to be really cautious about the movements we select in order to improve mobility, we also have to make sure that we educate our patients to say, hey, look, there are certain things that are probably okay to do at home, but there's other things that aren't, right? So we have to be on the lookout for that. Now, I'm just going to go ahead and rattle off a bunch of physical therapy exercises that are very common after rotator cuff repair in order to improve range of motion. These are generally considered either passive range of motion or active assist range of motion exercises. Keep in mind, we're shooting for 15% MVIC or lower. I'm going to say these exercises in order of easiest to hardest. First one would be pendulums, and that's got an MVIC of 14. Table slides are 15. Assisted wall slides are also 15. Rock the baby and circumduction is 17. And I've done YouTube shorts on these exercises. I'll put a link in the show notes so you can see what I'm actually talking about. Dowel assisted external rotation standing is 18. Dowel assisted elevation is going to be 20. Pulleys, so standard pulleys after shoulder surgery, are 20. Rock the baby into elevation is going to be 22. And just to give you a point of reference, active flexion is going to be 43% MVIC, and active abduction is going to be 48 MVIC. I apologize to the folks that are not watching this right now, but if you're going to be listening this in a podcast, go ahead and go over to YouTube at some point or go over to Spotify and watch the video podcast of this so you can see what I'm talking about right now. We actually have images of all of those exercises, and I'll just read them off to you. So in the far top left, we have the pendulum. Next to it, that is the rock the baby circumduction. Next to that is rock the baby pendulum. Then we have our table slides. Then obviously you can see the pulleys. Then we have the assisted wall slide, the dowel assist elevation, and then dowel assist external rotation. Now, I know that, this is not the best way of describing these exercises. It's tough to see in a podcast format. That's why I made a video of these. So I have a YouTube short as well as Instagram reel. All these exercises, I'll put a link in the show notes so you can just check those out and see what those movements are. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free Mini Course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. So what are some of the principles about early range of motion exercises that I give in terms of the home exercise program? So for one, I try to educate folks about frequency over intensity, right? We're not trying to jam this shoulder into the end range. I really don't want to do that. I think that's probably going to put quite a bit of stress on that surgical repair. I think that's a bad thing, right? But we do want to very frequently move this, okay? So it's kind of low level stretch where you feel a little bit of a pull and then you back off. The big thing is we're trying not to blow through pain. I also think that if this shoulder ends up getting a little bit more stiff, I think that's probably good, right? So keep in mind, this was a large full thickness tear with retraction. So that's one of those tears that has a high likelihood of re-tearing. We probably want that thing to stiffen up a little bit. We like to have a nice scar forming, making that nice and strong attachment to the bone and hopefully decreasing likelihood this re-tears over the course of time. In terms of how often I tell my patients to do these movements, I like to have them a couple times a day. So 2 or 3 times a day, maybe 10 or 15 repetitions each. So this was one of the most boring home exercise programs I think I've ever written. But essentially from week 2 to 4, the movements that we used at home were pendulums, circumduction, and we also had some neck turning. So some side bending, some neck turning, just because the neck was pretty painful in the beginning. Week 4 to 8, we added some PVC supine flexion. We added in some table slides, some ball rolling, and some assisted external rotation. So we had very low level exercises up until week 8. And generally speaking, I asked Brian to do these 2 or 3 times a day, 10 to 15 repetitions. And I never really had to change the frequency just because his range of motion came back so well. It's pretty easy from that standpoint. So like I said, the other piece we had to educate Brian on is just how much stress goes through the rotator cuff with daily activities. Now, for one, Brian was wearing a sling at all times for the first 4 weeks, and that actually makes my job quite a bit easier because I know that they're probably not able to do as much on their own if the arm is kind of glued to their side. They're not able to use it for anything, right? So keep in mind our goal of having less than 15% MVIC on that rotator cuff repair in order to keep things safe, right? And also, if you want to check out these studies, I'll leave them in the show notes. But essentially, I'm taking this information from Long et al. In 2010 from JOSPT. And they're looking at activation of the shoulder musculature during pendulum exercise and light activities, right? And largely, walking using a mobilizer or not is very low stress on the rotator cuff, less than 7% MVIC. Do keep in mind that some folks will aggravate their shoulder and get a little bit flared up just because they walk too much, right? So if that's a 7% MVIC contraction, but you walk for 5 miles, that's a lot of repetition. And despite that being relatively low stress, it's a lot of reps. Sometimes that aggravates shoulders, right? So you just have to educate Brian about that. Don't go for any crazy walks or anything early on. Make sure we build a little bit of control within that joint, get a little stronger before we start incorporating more of that, right? Typing is also largely safe. That was 7.5% MVIC. Brushing your teeth is also safe as long as you're careful. That's going to be 12.1% MVIC or less. Once we get to drinking, it's too much, right? So if I just essentially take a glass of water and put it to my mouth and start drinking it, that's 21% MVIC. So a little too much stress on the cuff, right? So we want to try to limit drinking with that surgical side. Eating is kind of the same story. Eating is somewhere between 14 and 32%. So if I'm eating food, pasta, whatever it is, that's going to be 14 to 32% MVIC, EMG of the supraspinatus. If I rest my elbow down onto the table and eat, it is better. Okay. So if I go in the shower and start washing myself, washing my hair is the toughest thing for my shoulder. And that's 23 to 57% EMG of the supraspinatus, which actually is more than just doing abduction exercises, full can exercise, abduction exercises, right? If I lean forward to wash my hair, it's a bit better at 6% to 36%, but you still do risk putting too much stress on that tendon. So largely for the first 8 weeks or so with Brian, we had to be quite cautious, and I just had to educate him about this and just make sure he understands that we have to protect this. Like I said, he had a sling for so long and a mobilizer, it wasn't a huge concern for me. So what did PT start to look like at week 8 through 10, right? Now I'm saying strength in quotes just because we weren't really doing any strengthening at this point. We're just very slowly incorporating a little bit more movement. I was doing these exercises 1, 2 times a day for about 10 to 15 repetitions. We're starting off with some basic isometrics, right? So 6-way isometrics, kind of working all sides of the shoulder, flexion, extension, internal rotation, abduction, a deduction, and external rotation. So flexion, extension, abduction, adduction, external rotation, internal rotation. And essentially, it's a very light contraction, 10 to 15% of max. We're really not pushing too much. At this point, we're incorporating a little bit more active assist range of motion. So assisted scaption, assisted abduction. And these are actually fairly low stress on the rotator cuff if you compare it to, let's say, a pulley. So I think it's important that you understand these EMG numbers so you can make some better decisions about which are the best movements to start with as we start to progress into the later stages of rotator cuff repair. We were doing some active range of motion with a prone extension row. A prone extension or a rowing motion in prone is actually very low stress on the supraspinatus, so a pretty good place to start, right? We also started to do a little neuromuscular electrical stim at this point. And we started off by stimming the infraspinatus. Thought being is that we don't want to put too much stress on the supraspinatus early on. So we can put the stim directly on the infraspinatus. And over the course of time, we can start to add the stim onto the supraspinatus, which I think we delayed until week 10. We started to put that on. In terms of placement for the stim pads, again, I apologize for the podcasters out there, but generally we use a larger pad and we put it directly over the muscle we want to target. So we take a large pad directly on infraspinatus, and then when we got to week 10, we put a large pad directly over supraspinatus. Once we got to week 10, so basically between week 10 and week 12, we bumped things up a bit. So from a strength perspective, we're now working on active range of motion. And again, I'm doing these dailies, 2 to 3 sets of 10 to 15 repetitions, and we're focused on scaption, abduction, sideline external rotation, T's, and supine scaption. We're starting to incorporate a little bit of a resisted range of motion, but it's only for prone extension and prone rows, just because these movements are very low stress on the supraspinatus. And again, we're incorporating NMES, neuromuscular electrical stim, while we're doing this. We're doing it twice a week, each time he's in the clinic with me. And now we're putting the electrodes in more places. So essentially, we started with infraspinatus. We added the supraspinatus. We can also put some electrodes on that mid and low trap. If you're looking at the image on the YouTube video or the video podcast, you can see exactly where these electrodes go to help you if you want to try to set this up on your patients. At this point, we also started to introduce some blood flow restriction training. If you've never heard of BFR before, blood flow restriction training is BFR. You only need a very low load to improve strength and hypertrophy. So 20 to 30% of your 1 rep max to increase strength and hypertrophy at a similar rate as performing heavy lifts at 80% of your 1 rep max. So if we're concerned about putting too much stress with the rotator cuff, one of the ways we can still get some strength and hypertrophy is by applying blood flow restriction training, which I think is a great idea for these folks. So we did BFR twice a week initially, and we start with lower reps. So traditionally, when you do blood flow restriction training, you do higher reps, 30, 15, 15, 15 is a very typical set and rep scheme. I usually start with sets of 10 to 15. And if that's tolerated really well, then we start to increase the reps. Because if you take someone that's very, very much used to doing sets of 10 and have them do a set of 30, that's a big jump in volume. And it can be pretty aggravating for these folks. So we just slowly increase the reps over the course of time. At this point, we're also doing a little bit of arm and grip work. And that would essentially be unweighted curls with a gripper. So basically taking a hand gripper and squeezing it while you're performing bicep curls and tricep extensions, right? So we did gripper squeeze kickbacks as well as an active range of motion elbow flexion. So bicep curl with a gripper. When we got to week 12, again, we just bumped things up a little bit more. So all those movements that were active range of motion, we turned them into resisted range of motion, right? And the thing is, once we increase the intensity of exercises, usually I like to have a little bit of rest in between days, right? Or at least we're not doing the movements as frequently as opposed to when they're active range of motion exercises. So in terms of the motions that we were loading, they were scaption, abduction, sideline external rotation, T's, Y's, prone extension, prone rows, sideline scaption, supine scaption. So think about eventually I want to get back to dumbbell bench press. And if I lay on my back and perform scaption, it's a very similar motion. So it's just a specific movement I like to put in my cuff repairs who are trying to get back to strength training in the gym, right? We continue doing NMES with these movements. So targeting infraspinatus, supraspinatus, and the mid and lower trap. We also continue on with blood flow restriction training. We now get back to our high rep step scheme. So we're doing 30 repetitions, 15, 15, 15 repetitions of scaption, prone extension, prone row, and arm work. So again, we're just beefing things up, more repetition. In terms of arm strength and grip work, now I'm starting to add load. We did bicep curls as well as tricep extensions light with a cable, and we added a little bit more weight. Typically, when you think rotator cuff repair, you don't think to work the arms, but they get weak just like everything else. So we just need to make sure that we have that on our radar and we improve arm strength as we start to progress along. Once we get to week 14, we actually start to create a program that looks a little bit like a training program. And this is pretty much my format moving forward. So generally speaking, I end up having different exercises on different days of the week, just like you would have with a traditional strengthening program, right? So I have a day 1, a day 2, and a day 3. This would be like a Monday, Wednesday, Friday. So on day 1, we have sideline ER. We have a push-up plus, which is quite a bit of stress on the supraspinatus, but we want to be able to tolerate that in order to be able to press things over the course of time. And we have a TRX row, right? So now you're starting to see a little more of traditional strengthening exercises, right, that you would see in a regular training program. Day 2, we have scaption, a push-up plus, an incline bench dumbbell seal row, right? So starting to bump things up a little bit more. On day 3, we have a band IR. We have a dumbbell serratus punch on your back and a dumbbell single arm row. I just want to make sure he's not posting with his surgical side arm because that can put quite a bit of stress through the rotator cuff. I want to make sure we slowly dial that up. So we have our basic strength days. We have our Monday, Wednesday, Friday strengthening. And on the off days, so 2 to 3 days a week, that would be Tuesday, Thursday, potentially Saturday, we want to perform a rotator cuff program. And my phase 1 exercises of choice are going to be sideline external rotation, scaption, band internal rotation, A's, and T's. I prescribe 2 sets of 10 to 12 repetitions of each. Now, this is a little bit redundant with the exercise that we just talked about in the strength program. But as you'll see a little bit later, the strengthening exercises get buffed up, so they're a little bit more challenging. And the rotator cuff work is very different from the strengthening exercises, right? But for now, it's not. But I'm trying to make that transition to a regular training program. Once we get to month 4, it's really starting to look like a strength training program. And usually this is at the point where patients are starting to feel a little bit better about their rehab. This is a tough recovery psychologically. And I think the big thing is that A, it hurts a lot in the beginning stages. B, you have to do so little for so long to protect the healing repair. And then 3, it's actually very hard to get your strength back just because you had such a period of time where you had to unload the shoulder, right? So this is usually a pretty good time frame for patients. Starts to feel like they're training again. We have some training movements we're starting to move back to that patient hasn't seen in months, and it feels pretty nice psychologically. So day one with Brian at month 4 was dumbbell bench press, dumbbell bent over row, a ring or T-Rex row, kettlebell bottoms up straightest punch. And again, if you guys want to see this, you can just go over to YouTube and you can pretty easily just, screenshot this. You can see exactly what it is, save it if you like to for future reference. On day 2, we had shoulder taps, half kneeling overhead pull down. So starting to get a little bit more range of motion within the shoulder from a pulling perspective. Keep in mind, eventually Brian wants to get back to pull up. So this is the way we start to progress that way. We have an incline bench, dumbbell seal row, and lastly, a push-up plus from the elbows, which is just a little bit more challenging than a push-up plus in a plank position. Day 3, we have a dumbbell press, we have a dumbbell seal row, we have a dumbbell single arm row, and we have shoulder taps, right? So keep in mind, and I said this previously, a plank plus position, right, or dumbbell press increases the stress on the rotator cuff substantially. Okay, so supraspinatus, infraspinatus takes quite a bit of stress when we press something. This is the reason why we're not seeing this until month 4. My recommendation is not to blow through a lot of pain. So patients oftentimes are using very light loads once they start initiating pressing. Okay. Now, if you had to put an RPE on that, that would be maybe a 6 or 7 out of 10 RPE. So it's not like you're doing 8 or 9 out of 10 RPEs for these exercises. I tell folks for the rowing movements, it's probably okay to push it a bit more. But for the pressing, we're being pretty conservative, right? Especially since it can be a little bit sore early on. I remember with Brian, once we started to introduce some of the pressing, he's like, yeah, my shoulder is a bit more sore than it usually is. And I think that means you just have to be very cautious with your progression. So our rotator cuff work and off days didn't really change much from the last 2 weeks. The only thing that did end up changing was going to be the reps. So we're doing sets of 10 to 12 repetitions and went down to 8. Just because as we get stronger, we're able to tolerate a little bit more load, which is going to be beneficial because eventually Brian wants to do things like push jerks, nice and heavy push jerks, right? So we go from kind of light weights, high reps, and we work our way down to lower reps, higher loads. So our blood flow restriction work also gets beefed up at month 4. So we were doing BFR twice a week. Now we're doing it 1 to 2 times a week. So I slowly transition away from BFR over the course of time. But the movements we're choosing are now getting more challenging. Okay. So the movements we're choosing now at month 4 are going to be an incline push-up, a lat pull down, a biceps curl with dumbbells, as well as cable triceps press downs. We're doing 30, 15, 15, 15 repetitions. That's 30 repetitions followed by 30 seconds rest, and then 15 repetitions followed by 30 seconds rest, then 15 repetitions followed by 30 seconds rest, and then 15, right? Straight through, no supersetting. We're trying to drive as much blood into the target muscle, per set. So that means supersetting is not going to help with that, right? So if you're supersetting a pulling and a pressing motion, we are probably not getting the same effect just because we're not pumping up that muscle, the target muscle group, as much as we would if we just did straight sets. Month 4 is also when we first do our handheld dynamometer strength testing. So isometric strength testing. Now, the reason why I hold off until month 4, and to be honest, I'm still a little bit scared at month 4, is just because if you're trying to have someone push as hard as they possibly can, then in theory, you are testing them at 100% MVIC of the supraspinatus, the same exact tendon that they just repaired, right? Surgically. So I think we have to be a little cautious with this. The other piece to keep in mind is that, we're probably going to be a little bit weaker on that side. We had a large period of time we were unloading this, and it's only been a month or 2 since we started to put some stress through this tendon, right? Which is probably not going to be super strong, right? So if you are fearful that you're going to potentially injure your patient, you can always wait a little bit longer. Do keep in mind that the majority of rotator cuff re-tears after repair occur in the first 0 through 3 months. So when someone's around the 4-month mark, I'm a little less concerned, although there are still re-tears reported somewhere between 3 and 6 months after rotator cuff repair in our medical literature. Just something to think about, right? But we did our strength testing starting around month 4, right? What was kind of cool is that the only movement that was different side to side, and we measured external rotation, internal rotation, scaption, and extension, was external rotation, right? So on the right side, he had 23.4 pounds of force. On the left side was 29, right? So he was actually pretty dang close. And what was kind of cool is that cleaned up over the next month. So we strength tested again at month 5, and he was symmetrical in all the movements. So good job, Brian. You got everything back pretty dang quickly, right? It's pretty cool. A few thoughts. So essentially, you can utilize the handheld dynamometer testing as a guideline of when you can kind of push certain movements. So one of the thoughts in my mind is that I like to do majority unilateral exercises or dumbbell exercises until we restore symmetry. Reason being is if we start doing barbell lifts, there's a good chance you're just going to compensate just because one side is going to be so much stronger than the other. And in my mind, it's safer to start introducing barbell or bilateral movements once we've developed some symmetry between sides, right? When you're measuring external rotation, you're measuring largely infraspinatus. Infraspinatus is very much responsible for horizontal pressing. So for Brian, I probably don't want to put in a whole lot of barbell bench press just because he doesn't have symmetry between sides yet, right? Same idea goes for internal rotation range of motion. So internal rotation measures subscap. The subscapularis is very active during horizontal rowing. So if he had a mismatch between strength left to right for his internal rotation, I probably wouldn't push a lot of barbell rowing. All right. In terms of scaption, think about the movement scaption. It's pretty much the same arm path, right? Shoulder path, abduction, flexion as a barbell overhead press, right? So if you're not symmetrical here, I wouldn't start doing a whole lot of barbell overhead press. And lastly, I like to measure extension because in the gym, we do a lot of resisted extensions. Think about every single row, pull down, pull up. That's all extension. So if you don't have symmetry here, you have to be careful about initiating things like pull ups, pull downs, and the like. So as we get to month 5, we really just start to ramp things up more and more. Day 1, we have an incline dumbbell press. So we went from a flat dumbbell press now to an incline. So we're starting to work more and more overhead, which in theory is going to be more stress on the rotator cuff. We're doing barbell corner rows, so a double arm exercise for rowing, right? Because we've displayed that we have symmetry of the subscap with resisted internal rotation extension. Seated cable rows, a plank turn. On day 2, we have a half kneeling landmine press. So we're starting to press more and more overhead. Like I said previously, Brian wants to get back to a lot of overhead activities. So you have to slowly ramp our way there. Incline dumbbell press and landmine press, a great way to start to progress your way there. A half kneel cable pull down, trying to develop symmetry with overhead pulling. That's a great way to do it. We have incline dumbbell seal rows, and we have forward and backwards crawling. So we're just increasing the challenge of our plank plus and shoulder tap exercise variations because eventually we want to be able to do handstand walking, right? So I'm thinking, how do we progress back to all those movements and how do we kind of dose things from easy exercises to hard exercises? On day 3, we have a lateral inchworm, dumbbell seal row, landmine barbell single arm row. We have a push up. We have a dumbbell Turkish sit up. So I love this exercise, the progression back to stabilizing weights overhead. So eventually Brian's going to want to be able to snatch, clean and jerk, and perform handstands. I think get up variations are a great way to start working towards that goal. Month 6, we're just beefing things up again. So day 1, we start off with a 60-degree incline dumbbell bench. We're going to alternate between sides. Largely, we're just increasing that incline more and more, getting closer to overhead. Now we're doing pull-ups, right? So essentially, it's a band assisted. I want to have a 1-second pause and full hang. I don't think we think about this often as physical therapists, but when I'm doing, let's say, a kipping pull-up, the hardest portion of the movement on my shoulder is hitting that bottom range of motion, right? Because essentially, you use your core and lower body to create momentum to get your chin over the bar, and then you drop straight back down to the very bottom portion of that pull-up. So we need to develop a lot of strength and preparation in the bottom part of the pull-up. So when I do pull-ups initially, I like to have a pause in the bottom end range to develop some strength control there, right? On day 1, we also had a barbell bent over row. And lastly, we have a pike position shoulder tap. So we're getting upright. We're starting to put a very similar stress on the spine as handstand walking, on the shoulder as handstand walking, but we're not actually handstand walking yet, right? So we're just being creative about slowly ramping up that stress over the course of time. Day 2, first exercise, a dumbbell seated overhead press. Now, this is our first foray into overhead pressing that we've done in probably about 8 months, right? So it's been a large period of time. We've backed away from this, and now we're starting to introduce it at month 6, right? We're also doing a band single arm pull down, and this was basically because Brian did not have access to a cable. And lastly, a modified wall facing handstand push-up, right? So handstand push-ups, obviously a big part of CrossFit. We want to make sure we don't go straight back to handstand push-ups. We modify them. The loads are not that challenging on the shoulder. We're going to build our strength up with dumbbell seated overhead press, and we're starting to get a similar stress through the shoulder by doing a modified wall-facing handstand push-up. As we build more symmetry with the dumbbell overhead press from a strength perspective, we can start to leak in more regular handstand push-ups, right? On day 3, we have wall walks. So think about our progression that we've started with. So we started with a plank position shoulder tap. We worked towards a crawl. Now we're doing a wall walk. So we're just kind of sequentially increasing the stress on the shoulder, working our way back to things like handstand walking, right? Going to superset that with a dumbbell seal row. This day, we also have a landmine barbell single arm row. We're doing a box dip. So essentially, we're going to end range shoulder extension and pressing back out of there. That's pretty challenging motion on the shoulder joint. So I usually incorporate this a little bit later into rehab, right? Usually I like to tolerate push-ups first, and then I do an assisted box dip, and then we can do an unassisted dip. And lastly, we can do ring dips. And after that, muscle ups, right? Because essentially when you catch yourself in the bottom position of a dip and a muscle up, right? We need to have strength and preparation there. And I build that by doing a lot of dip variations and working our way up slowly over the course of time. And the last exercise on day 3 is a dumbbell windmill. Phenomenal exercise. It mimics the same stresses the shoulder takes while snatching, right? So think about the bottom position of overhead squat, the receiving position of a snatch. The shoulder has to be an end range, external rotation, abduction, right? Maybe not end range, external rotation, but pretty dang close, right? And a dumbbell windmill is going to be a very similar stress, but it's less dynamic, a little bit more stable, prepares the shoulder for that movement. At month 6, we also beefed up the rotator cuff program. So essentially, there were 3 days per week of strength and then 3 days per week worth of rotator cuff work, right? And essentially, our sideline external rotation turned into a side plank ER. We're still doing scaption, but we're adding a pulse at the top. The T's are the same. We incorporated Y's now, and we're doing band external rotation, internal rotation at 90 degrees of shoulder abduction with the general goal that we want to try to get more proficient with overhead movements. So we started with rotator cuff exercises that are more elbow at the shoulder, right? Elbow below shoulder level. Then we progress towards elbow above shoulder level. Obviously, that's going to be replicating the stresses on the shoulder with overhead activities. It was at this point, so at month 6, where Brian and I decided that it was okay to return back to CrossFit. Now, I think Brian probably could have gotten back a little bit sooner, but in reality, once you start sending folks back to CrossFit, you're losing control of the stresses you're placing on the shoulder joint. So I think waiting a little bit longer is probably going to be a little bit safer than sending folks back, right? And the other piece is you need to give people some sort of idea about what's okay and what's not okay. And in the early stages after rotator cuff repair, you're going to need some heavy, heavy modifications, all right? What I like to use is a patient-specific functional scale. That's basically an outcome measure that's popularized in the physical therapy world. And in terms of the movements I have in my patient-specific functional scale, I have a patient-specific functional scale that has every single CrossFit movement in the gym, right? And essentially, I go down the list and I try to figure out which movements are okay and which ones aren't okay. And I make modifications for every single movement that I don't think are okay at this point. So when Brian goes back to the gym and some movement shows up, he knows exactly what to do. There's no guesswork. There's no coach there that has to make a decision about what's okay and what's not. We don't put Brian in a weird position where he doesn't know what to do. I tell him exactly what to do. I think that's how you keep your patients the safest. Now, there are a few general principles I use in order to slowly leak exercises back into a CrossFit training environment. I like to make sure that we try the movement first in a physical therapy setting. All right. So, a good example would be, let's say, an overhead press. I don't want the first time that Brian tries an overhead press to be in a CrossFit Metcon. I think that's a really bad idea, right? Let's start this off in a much more controlled environment in physical therapy clinic. I can watch the movement. I can see how it looks, right? I can make modifications if it doesn't feel good, right? Once I've done it for a few weeks and I'm confident that Brian can actually do this in the gym, then I allow Brian to do this in a controlled skill or strength environment. Okay. What I mean by that is that usually in a CrossFit class, you have kind of a skill session, strength session, then you have a Metcon, right? So if overhead press is showing up in the skill session or the strength session, then go for it. We know it's probably going to be safe. We did this already in physical therapy. Now, what I don't want Brian to do is that he just takes that movement and does it in a Metcon environment. I think we're skipping a step there, right? So ideally, I like to have folks try that movement first in physical therapy and then transition over to doing that in a strength or skill environment. And once they've built some competency there, lastly, you can incorporate that movement into more of a Metcon environment, right? And that might be about a 6-week period, right? So you maybe introduce day 1, you introduce overhead press in a physical therapy environment. 2 weeks later, introduce that into a strength and skill environment in the CrossFit gym. And then at week 4, you start to introduce that more in a a Metcon environment, right? So it's kind of a slow progress or process, excuse me, but I think it's a nice, safe one. Now, month 7, it was a pretty interesting transition period. Now, what do I mean by that? Well, largely from a physical therapy perspective, as your patients start to get back to their activities, right, and doing more and more of their sport, we actually start doing less and less physical therapy. And one of the reasons why is if your athlete is returning back to their activities or their sports, and you also have a very large and robust physical therapy program, it might end up being too much stress on the given area, right? Like the shoulder. So as Brian was starting to progress more and more into doing training at the CrossFit gym, we started to pull back on some of the rehab exercises. So what you'll see here is the program is actually a little bit smaller in month 7 compared to month 6, right? But the movements we're doing now are a higher level exercise. Okay. And I'll show you. So, day 1, we're working on jerk recoveries. We're doing dumbbell overhead press, and we're doing pull ups where we pause at the bottom. Okay. So, a lot of strict strength. We're working much more on overhead strength and stability at this point, but there's only 3 exercises. Day 2, we have a snatch balance, a dumbbell windmill, and we're doing dips with rings, but we're doing a ring thing dip, which is basically an assisted ring dip. If you don't have access to a ring thing, which I do recommend getting, if you're going through, let's say, some sort of big shoulder surgery and you're looking for some way to modify your gymnastics ring skills and try to slowly build strength and competency, ring things are phenomenal. But if you don't have it, you can always spot yourself with your feet, right? So if you look at these movements, we're getting very, very close to Olympic weightlifting and gymnastics movements you typically see in a CrossFit training gym. And we only have 2 strength days, right? So it's just a day 1 and a day 2, whereas we had 3 in the past, okay? From a rotator cuff perspective, our rotator cuff exercises are just getting a little bit more challenging, a little bit fancier, and we've added in a Cuban press. So if you've never seen a Cuban press before, it's kind of like the turnover in a snatch. So elbows high and outside and then flipping up. So think about using light dumbbells and going into that scarecrow position, elbows high and outside, and flipping the weights up into external rotation and then right back down again. We're mimicking the turnover position of a barbell snatch, basically, right? And essentially, like I said, we're doing less with physical therapy because Brian is doing more from a training perspective. So that's nice. So here we are at month 8, and you can see we have a similar setup as last month. It's just that now the movements are even more challenging. So on day 1, we're doing push jerks. I like to add a pause at the top position of the lift because we're trying to build competency there, right? Next exercise is dumbbell waiter's walk. So again, building competency at end range shoulder flexion. Then we have a hanging leg raise. And this, in my opinion, was our introduction to more kipping movements. However, Brian was not in a hurry to get back to any sort of kipping movements, and he actually wanted to have some more time to work on his competency and strength with strict pulling movements before we got into more dynamic exercises. So we actually didn't give those movements to him, right? Day 2, Brian's doing a hang snatch. So this is the first time he's doing a hang squat snatch, right? We're pausing in the hole because I think that the hole of the snatch or the bottom position over a squat is probably the most challenging position for the shoulder. So I want to establish a little bit of strength and control there, right? So over the course of time, when we do more dynamic snatch variations, we have the control we need in the hardest part of the lift. Second exercise, a dumbbell push press. So we're making our dumbbell press a bit more dynamic. I like controlling that eccentric portion just because I think that's one of the hardest parts about push jerks. So we're developing control there. And lastly, we have a slow hollow arch on the bar. This is our transition back to dynamic kipping work, right? Again, we didn't want to rush this because Brian just didn't have that goal. He wanted to take his time, right? And our rotator cuff program was largely the same. We're doing that 2 days per week. So after month 8, Brian actually transitioned out of physical therapy, right? Because at this point, I was pretty confident that we had kind of taken him to the point where he was comfortable and I felt he was safe to start to transition back into the gym a little bit more. Usually this is a shared discussion between myself and the patient. Do they feel prepared? Do you feel like you're able to make those last few jumps, get back into training? Would you like more help or not? And I just largely felt that Brian's smart enough to make that transition back, right? Didn't feel the need to keep him anymore. And he kind of felt the same. He was ready to kind of spread his wings and fly away. Now, I did end up seeing Brian a couple more times in the future, but they were just much more spaced out visits. And largely at month 9 to 12, my guidelines were to slowly ramp up intensity and volume, right? So even though we've kind of run through all the movements from a rehab perspective and slowly integrated that into our CrossFit classes, doesn't mean we should just go nutty in the gym and train at the same intensity that we normally would. we still probably want to slowly ramp back up, right? So over the next 3 months or so, we just slowly ramped up the intensity, the challenge of workouts, all the like, right? We also gave him a little bit more guidance on how to return back to kipping movements. We didn't really have a lot of guidance on how to get back to a muscle up or more advanced handstand walking drills, right? Or more kipping, toes to bar. Future programs, I just gave him a few supplemental activities or exercises, getting back to those things, right? I also gave Brian a lot of education on trying to how to, or on some ideas of how to stay safe in the future. One big piece of advice was just trying to be careful about training spikes. So one of the things that's great and sometimes terrible about CrossFit is they love variety in their workouts. One issue with all the variety is that one week you may have, let's say, 300 overhead press and kipping pull ups, and the next week you might have 50 overhead press and 20 kipping pull ups. And the following week you're back up to 300 again, right? So the variety is fun, but the shoulder doesn't always like these huge spikes, right? So having a week that has a million reps and the next week has no reps and the following week has a ton of reps, just spiking that volume up and down, we know that's one of those things that influences our risk of injury, right? So what that means is that if you have a week that has a ton of stress, right? Let's say you have a workout that has 10 muscle ups, 50 wall balls, 50, I don't know, kipping pull ups, and then 50 overhead press, right? I might just tell Brian, let's cut down on the reps of some of these and maybe increase the reps of something else that doesn't stress the shoulder as much, just so you don't have an extremely challenging shoulder workout that day. And the other piece that I think we don't think about enough is that if you have a week that doesn't have enough stress, you probably have to add in that stress if you didn't do it throughout the course of the week. Let's say you just have a training week that has no dumbbell overhead press, has no strict pull ups, has no Olympic lifts like snatch or jerk work. You probably need to plug a little of that into your program at the end of the week, right? That way, we don't have a week that has absolutely nothing, and the following week has twice the amount that you had the prior week, right? So we want to avoid those spikes. If there's too much stress in a given week, we dose it down. If there's not enough stress in a given week, we dose it back up again, right? So, guys, I have another video that I want you to watch. It's an evidence-based guide to rotator cuff repair surgery. I'm going to leave a link in the show notes as well as a link above my head right here. So go ahead and click on that link if you want to continue the learning.